So we did this sort of prospectively designed observational study to look and see if we could define some risk factors that would be useful in patients who were turning up for cardiology review. And so we went through a process of looking at patients who had been referred for elective coronary angiography and then looked at 5-year outcomes. The key parts that we found here were that the major risk marker that was helpful to looking at long-term outcomes, and that's death, myocardial infarction and stroke, in patients who are assessed by cardiology is beta natriuretic peptide. So BNP was by far the outstanding marker here that could determine outcomes. And it's important to remember that this wasn't the heart failure cohort. These are small elevations in BNP, but with a cutoff of 100 picograms per mil for beta natriuretic peptide, we could very clearly distinguish patients who were going to have adverse prognosis. The other takeaway from the study was that standard risk factors, so the usual Framingham type risk factors, age, cholesterol, blood pressure, etc., were not very helpful here. And the reason for that is, of course, we're all very good as cardiologists at treating those risk factors, and where necessary, of course, patients get revascularized. So all of those risk factors don't tend to mean much for long-term prediction of risk. We also assessed a whole array of novel risk markers, and unfortunately none of those either came up to scratch. So we looked at pulse wave technologies, which look at compliance and pressure changes in the arteries. We looked at heart rate variability, which looks at autonomic function. We looked at CRP, which is a marker of inflammation, and a whole host of other things, but unfortunately none of those were very useful for long-term prediction, purely because of this factor that there's a lot of modification of risk. And that means that those sorts of factors are no longer relevant if you're looking at long-term death or MI. So we conduct the study because there's a distinct lack of information about risk factors for cardiology patients. Now we have to remember that it's a very different population than, for example, the Framingham and SCORE cohorts, which are generally patients who don't have risk factor treatments, and they don't have previous coronary disease or strokes, etc. So the patients we see in cardiology are very, very different. They have high rates of cardiovascular disease, which means you can't use traditional scores like Framingham. So that's the one thing we want to do, is to look at long-term predictors. And we want to do that in as robust a fashion as possible. Now, of course, it's not ethical to randomize patients into that sort of setting because they're all undergoing clinical treatment. But we tried to emulate as much as possible of a randomized trial by blinding all of the risk markers for the entirety of follow-up. So we were very careful that none of the clinicians were aware of the risk markers and their results. And then all of the outcomes were independently adjudicated by clinicians outside of the study team. So we tried to adopt things to minimize bias where we could. So the original cohort was 550 patients who were recruited as they were going through for elective coronary angiography. Obviously there were some patients who weren't appropriate for the protocol. So we ended up with, I think, 526, 530 patients. We only lost 4 patients to follow-up, which is less than 1%. So we have a great deal of information on a sort of a mean follow-up at 5 years for these patients. So the main results were that standard risk factors were not associated with long-term prognosis in these patients. So things like age and smoking and cholesterol and blood pressure, etc., were just not very helpful. And the reason for that is, of course, is that we're very good at modifying those risk factors in clinical practice. And now all these patients had coronary angiography, and we were very lucky that there were 20% who were entirely normal coronaries, 20% who had minor irregularities, and then 20% in each of the categories who had single, 2-vessel and 3-vessel disease. That was just by chance, but it also gave us a nice use to look at coronary angiography as a marker. And yes, all of those patients, the patients who had more severe disease were more likely to have adverse events on follow-up, but actually it wasn't a very good discriminator. And again, the reason for that is we're very good at revascularizing patients who've got significant lesions. So the standard risk factors really weren't that helpful. In terms of the novel risk factors, again, it was a bit of a disappointment. pulse wave analysis, which is used in lots of studies now as a surrogate marker, was simply not helpful. And I think the reason for that is because it just uses the existing risk infrastructure, if you like. This is all about blood pressure and its response, which is all contained within standard risk factors. Heart rate variability, which we had good hopes for as a sort of a marker of autonomic function, again didn't seem to be useful in long-term prognosis. In the short term, it was associated with events, but over time, as people presumably had ACE inhibition and other treatments, beta blockers, etc., that link with outcomes no longer persisted at 5 years. C-reactive protein was not associated with outcomes at all, and that's been, I think, observed in a number of different cohorts, again because it probably links in with the existing risk factors that are being treated. But the key outstanding factor was BNP, so B-type natriuretic peptide. That's a marker of, if you like, subtle cardiac strain. Now, these are not heart failure patients, so these are patients who had small elevations in their BNP. But even at a small cutoff, so a BNP cutoff of 100, those people above that had somewhere between 2 and 4 times the events that patients with a low BNP had. So it's a very good discriminator of patients who will have MI, stroke, and death at a long-term follow-up from when you see them. So I think the key bits of practice will be maybe a focus on BNP as something that's useful, not just in heart failure patients or diagnosis of heart failure, but also in the coronary disease cohort. Now, BNP is raised in a number of different conditions, but we've shown that these small elevations in the context of coronary disease can help to identify those patients who are going to end up either dying or having a stroke or MI. So that's a clear benefit for people, because we could potentially see, for example, a clinician testing a BNP, very cheap and widely available test in patients with coronary disease, but with normal cardiac function, seeing a BNP of whatever, 150 or whatever, and saying actually to that patient, look, you've got a higher risk, so we need to focus our efforts on getting your risk factors down, revascularizing what we need to do, and keeping a very close follow-up of you so that we can quickly identify if there are other issues that, that need cardiology intervention. So I think that's the key thing. The other bits are more translational. I think people need to be very careful about using things like pulse wave analysis, heart rate variability as surrogate outcome measures. It's being done in a lot of studies, but I think our data suggests we need to be cautious about that because in the long term they may not be associated with outcomes.